Hi, thanks for tuning in to episode number 63 of the Doctor Podcast Show. And I'm your host, Dr. Robert Seichert. Today, we have a great episode with a great guest. We're going to be talking about four of the most common words on the internet. And those words are Ozempic, Wegovy, Mounjaro, and Zepbound. Everybody's talking about them. It's in the news all the time. And today we have an expert on that and also a board certified cardiologist who's an expert in cardiology. It's Dr. Tyler Gluckman. Dr. Gluckman is at the Providence Heart Clinic in Portland, Oregon. He's the medical director of the Center for Cardiovascular Analytics Research and Data Science at the Providence Heart Institute. Dr. Gluckman did his internal medicine training at the prestigious Northwestern University in Chicago, and then did a cardiology fellowship at one of the top cardiology programs in the country, if not the world, at the Johns Hopkins Medical Center in Baltimore, Maryland. Dr. Gluckman has published numerous papers relating to cardiology and other various medical topics, and we are fortunate to have him here today because he recently published a paper at the Journal of the American Medical Association, one of the top medical journals in the country, dealing with weight loss and these drugs that I just mentioned. So, Tyler, thanks very much for taking time from your busy day and schedule to appear on the Doctor Podcast Show. We really appreciate it.
Thanks for having me. I'm excited to be here.
Yeah. So you published this article, basically, which compared the semaglutides, which is Ozempic and Wegovy, versus the tirzepatides, which is Mounjaro and Zepbound, for weight loss. And what did you find when you compare those? To my knowledge, there haven't been any other head-to-head studies comparing those different drug categories. Is that right?
Partly right, or I would say mostly right. So as you led in at the very beginning, we are seeing growing use and data coming out about a broader class of drugs referred to as GLP-1 receptor agonists. Components of both drugs, semaglutide and tirzepatide, have that component. Tirzepatide is actually two drugs in one, if you will, that have two different mechanisms of action. Needless to say, these drugs have received the greatest amount of attention despite initially being developed principally to improve blood sugar control in patients with type 2 diabetes, as agents that can be used to facilitate weight loss in people who have diabetes, type 2 diabetes, or in those that do not. And we'll probably talk more about it, but an even broader array of different conditions, from chronic kidney disease to sleep apnea to those who have cardiovascular disease like heart attacks and strokes, are the subjects of recent trials as well. There was one study that sought to evaluate in a head-to-head comparison these two drugs limited to those with type 2 diabetes. What we sought to do was, in the absence of likely to be head-to-head comparative effectiveness studies, when we start broadening the array to extend to those individuals who are principally being prescribed these drugs to facilitate weight loss above and beyond any blood sugar control, and in particular for those that don't have diabetes, to achieve weight loss. How do these drugs compare overall? And to a large degree, these types of analyses prove challenging unless you have the ability to have very large data sets. So we looked at a very large real-world data set, pulling data from different electronic medical record systems, and we sought to match a population of individuals with or without type 2 diabetes to that similar type of population, looking at the use of these drugs in real world settings. And again, we looked at the drugs that are principally approved for the treatment of diabetes, but as you know, these drugs have been increasingly used even off label in patients to help facilitate weight loss. So we use the semaglutide Ozempic version and the tirzepatide Mounjaro version, trying to assess in a broad population how effective they were at promoting weight loss over time, and doing this in a propensity matched population. That term, if less familiar to some individuals, is a way of taking a real world data set where we don't randomize individuals by giving one population one drug and one population the other, trying to control for all of the things that we can think about that would control the populations to feel like they're similar populations being compared. And essentially, the analysis was conducted between May of 2022, September of 2023, and again, a real world analysis. And again, these were the drugs that were labeled principally for type 2 diabetes, knowing that some people had type 2 diabetes, some did not overall in this population. Ultimately, we found and demonstrated in the study that tirzepatide, depending upon which metric you wanted to look at overall, was associated with a greater achievement of weight loss, whether by a percent metric, 5%, 10%, or 15% weight loss. And then we also looked at absolute differences in terms of weight loss achieved as a percent of their total body weight as well. So I think this is one of the advantages of real world analyses to help us understand, in fact, differences or similarities between drugs that may not lend themselves practically to being studied in a randomized trial compared head to head.
So you found that basically one is better than the other in losing weight. Now, what's the difference between Mounjaro and Zepbound?
Yeah, so this is an interesting question. So let me go for that first, and I'll come back to it from the standpoint of where we see things from the Ozempic-Wegovy side of things. In the case of tirzepatide, as you had led Mounjaro and Zepbound, they're essentially identical drugs with identical dosing regimens, but different labeled indications. And so the Mounjaro version of tirzepatide as a brand name is approved for type 2 diabetes for improvement in glycemic control. Zepbound approved for those to achieve weight loss who have either obesity or overweight state with increased risk factors, additional risk factors. Essentially, you're talking about the exact drug, but looked at differently by name in terms of its underlying indication. In contrast, subtly different, Ozempic and Wegovy are both semaglutide. There are small differences in terms of the doses that exist under those two brand names, such that the Ozempic version approved for type 2 diabetes doesn't include as high of a dose of that medication as the Wegovy version overall. And on some level, this may seem confusing. In some respects, it's a little bit easier on the flip side, where at least you know, based on the drug that's prescribed, at least at a brand name level, what in fact the intent is overall of why you're prescribing it.
So based on your findings, if you have a patient that needs to lose weight, whether they're diabetic or not, you would go with the Zepbound version?
So I would say, again, this is a non-randomized trial, but our data, and this did look at the approved formulations of semaglutide for type 2 diabetes, so the Ozempic version of semaglutide, compared, if you will, to the Mounjaro version of tirzepatide. Part of that consideration was the fact that Zepbound had only recently been FDA approved. We wouldn't have had enough patients to be able to do that comparison. The other reality is many, but not all patients may have been given a version of the drug because it was more accessible, either because the supplies were more available, or because it may be more likely to be approved in somebody who may not have type 2 diabetes. And again, I wasn't a prescriber in this study, but you know, people may make choices to use drugs off label, and I leave that to them to decide. But at the end of the day, with that caveat in mind, tirzepatide outperforms semaglutide in terms of the magnitude of weight loss. And this parallels what we have seen in that one study that compared the two head-to-head for type 2 diabetes. And part of that may be related to differences in the drug themselves, partly to the fact that tirzepatide works by two mechanisms. And we are seeing in the weight loss arena that there is a whole cadre of therapies in development in the pipeline that may combine one, two, or even three mechanisms of action to help facilitate weight loss. And one would expect if you're tackling this problem by multiple means, you may be more expected to achieve greater weight loss. To be clear, both of them provide clinically meaningful improvements that can have an improvement on harder outcomes, what we may talk about.
What about comparing side effects of the two different drugs? Your article mentioned gastrointestinal adverse side effects. Did you find any significant difference between the drugs?
There were not any significant difference in the rate of adverse events from a gastrointestinal perspective. And for those that have ever prescribed this, or if they know people who are on it, nausea, potentially vomiting, GI upset can be a potential side effect that in the spectrum of uncommon side effects are more prevalent in those less common side effects, if that makes sense. So we focused in principle on those GI side effects and did not observe any significant difference in the likelihood of being associated with gastrointestinal adverse events.
Yeah, that's good to know. I've had some patients who've tried both drugs, and occasionally they'll have GI side effects from one or the other and switch, and then they're okay. So it seems to be a very individual thing as to whether you're going to have GI problems from the drugs. And
Yeah, I would also add, for us as clinicians, a lot of good that you can minimize these potentials for GI side effects by getting some good instruction about eating smaller meals throughout the day, not eating heavier meals, fatty meals, larger meals, all of which can create challenges or increase the likelihood of some of those effects.
right. Do we know yet how these drugs work? Every day I read new articles about proposed mechanisms for why people lose weight. Some of my patients tell me they just have reduced appetite, but some of them tell me they eat the same stuff, but they're losing weight anyway. So are they speeding up metabolism possibly, or some other mechanisms?
Easy answer is yes. These drugs probably are working by a variety of different mechanisms, both within the gastrointestinal system itself, but also in terms of promoting early satiety or a lesser desire to be hungry, and therefore you consume fewer calories and achieve their benefits that way. So I would say that we continue to learn about a variety of different mechanisms by which both direct and indirect favorable effects result from the use of these drugs. As I had mentioned beforehand, above and beyond weight loss, we are seeing these drugs being explored in a wide range of different conditions. Some that may be rather intuitive and linked back to a higher weight, things like sleep apnea or conditions like sleep apnea, where we know there's a relationship between higher weight and propensity for a condition called obstructive sleep apnea. If you lose weight, you would expect the opposite effect to result, and we've observed that. But there are other conditions that it's not as clear. And so there's probably a potpourri or a variety of different mechanisms by which it produces favorable effects. And more broadly, from a cardiovascular risk reduction standpoint, as was demonstrated in a large trial this past fall in 2023, where patients who had established clinical atherosclerotic cardiovascular disease, these individuals had had heart attacks or strokes at the end of the trial, didn't have diabetes, and showed a cardiovascular benefit. We know these drugs help lower LDL cholesterol, bad cholesterol modestly. They lower triglycerides, they lower weight, they improve blood pressure, but there are likely other mechanisms, a range of other mechanisms above and beyond that that convey favorable effects within the body.
Right. So jumping to the cardiology aspects of this, why is obesity bad for the heart? Let's assume you're not diabetic for a moment. You're just very overweight or obese. Why is that bad for the heart? And why does that increase the risk of heart attacks and strokes and things like that?
Yeah, so there are likely direct and indirect effects that occur. I will start by saying there is an increasing attention on the interplay between a lot of what are referred to as cardiometabolic diseases. In fact, the American Heart Association put out a presidential advisory last fall titled Cardiovascular, Kidney, and Metabolic Health. And it talked about the marked intersection between various forms of cardiac disease that are seemingly intuitive, like high blood pressure, high cholesterol, and the consequences from that, conditions like atherosclerotic cardiovascular disease, heart attack, stroke. We know there are associations also with other forms of cardiac disease, including arrhythmias and heart failure. And then there is an interplay with the kidney in predisposing to chronic kidney disease. And then other forms of disease, including sleep apnea, which in and of itself has deleterious cardiovascular effects. And then, in fact, what was previously referred to as non-alcoholic fatty liver disease, now called metabolic dysfunction associated liver disease, but the deposition of fat in the liver itself can incite inflammation, scarring, fibrosis, and ultimately cirrhosis. And so the central common underpinning from a cardiovascular standpoint is that excessive adipose tissue can have a number of effects overall. As we talked about, it can affect, in fact, total blood volume. You can see mild increases in heart rate, changes in the hemodynamic stressors on the heart, the pressures on the heart. It can accelerate the risk of developing high blood pressure, which itself has its own deleterious effects. It can activate in an unfavorable way the so-called neurohormonal system. It produces a number of metabolic derangements as well. And then you have the other side where sleep apnea can be associated with decreases in oxygen levels, particularly when one's sleeping. This creates its own stressors. And so it is I would say, a vicious circle by a multitude of different mechanisms by which it produces unfavorable effects. I would say that the unifying theme here is that we're talking about an individual who has excess body weight, and in particular, excess adipose visceral fat that is deposited that has and promotes a lot of these harmful effects.
Right. So these drugs that we talked about work in direct and indirect mechanisms. By having you lose weight, you're benefiting your heart, and also by reducing your adipose or fatty tissue, that's helping via all the mechanisms you just mentioned. So it's multiple ways, right?
Absolutely. And I'll start by saying if we can prevent this from occurring from the outset, we could have a tremendous downstream impact of a lot of the most common chronic diseases. And I should say upstream from that, risk factors that potentiate these diseases overall. Our hope, and to be perfectly honest, we have seen that to a large degree, many of the drug-based therapies that have been able to achieve weight loss, the amount of weight loss that they've been able to achieve historically likely has been insufficient to have favorable impacts on hard cardiovascular events, the development or worsening of heart failure, the development or worsening of coronary artery disease or stroke. And I think part of this relates likely to the various mechanisms by which it acts. But I would also say this class of drugs, GLP-1 receptor agonists, and those that have dual mechanisms like tirzepatide, extend the magnitude of weight loss to a level that really has been unparalleled from a drug therapy standpoint, and really begins to come close to approaching the levels, at least at the highest doses of these drugs, amongst a subpopulation that really approximates what we achieve with bariatric or weight reduction surgery. And so, and just to remember that that type of surgical approach or procedural approach to weight loss can have a number of favorable cardiovascular effects as well. So whether this is in and of itself related to the variety of mechanisms that we talked about briefly before, or whether this is related to the sheer magnitude of weight loss achieved, or probably a combination of both, is hard to figure out. And I think the excitement about the pipeline of therapies yet to be forthcoming is, we talk about drugs that can achieve upwards of 15+% weight loss, and in some cases, a smaller subset achieving 20+% weight loss with the drugs we have today. Some of the early data with drugs in the pipeline could be more regularly achieving 20, 25, even 30% weight loss.
Amazing.
Obviously, questions about what are the near-term and long-term concerns related to that. Are there undue concerns? Are there safety concerns in the near term and long term? But from a weight loss standpoint, really a transformational advance in healthcare.
Right. You mentioned some of the side effects. I interviewed a neuro-ophthalmologist from Harvard about a month ago, and he wrote a paper in the New England Journal where they found patients had vision loss rarely, so from something called ischemic optic neuritis. And there seemed to be an increased incidence in patients who are using these drugs. Have you seen any patients with loss of vision, or have you
I
heard of
haven't
those?
personally. Yeah, I'm familiar with the recent data that you just shared. And I think, this creates a vigilance for us that
Right.
will sometimes these effects require very large numbers of patients being studied to better understand if they occur, and if they do occur, how often they occur. And then the obvious question is, can we predict who may or may not develop any number of side effects so as to minimize the risks associated with it? So I think the onus will be upon us as a profession to continue to be vigilant about this. And is it proportionate to the magnitude of weight loss? Is it related to a certain drug used? Is it related to a patient? And perhaps risk factors that they may otherwise have yet to be fully figured out. But I think these signals are sometimes findings that we only find out about in terms of large analyses like the one performed.
Right. We'll eventually find out. Uh, what's peculiar to me is there's a component of the internet that seems to uh, be proponents of obesity or being overweight. You see it some in the entertainment business, where some entertainers who are clearly obese and overweight are saying, oh, there's nothing wrong with it. It's terrific. You shouldn't be ashamed of it. It's okay to put on tons of weight. How do you explain that? While at the same time, we have clear data that every doctor agrees upon that being overweight or obese is harmful.
Yeah, it's a hard thing to reconcile overall. What I will tell you is there is a ever-growing body of literature that talks about physical fitness independent of one's weight. So individuals may carry excess body weight and yet be very physically fit. And in contrast, individuals who may have lesser degrees of weight excess but be less fit. And so the fitness is, I wouldn't say a one-to-one compensator for excess body weight, but it speaks to the fact that simply just losing weight alone is not a sufficient solution to the problem. We're all looking for our silver bullets or easy buttons in this regard. And while there are certainly limitations to these therapies in that they're not for everyone, there are limitations in terms of affordability and access for patients. And notwithstanding, as we talked about before, all drugs, including these, have potential side effects and populations in whom they should not be used. But we cannot forget that there is an important backdrop, which maybe gets minimized way more than it should, and probably does, is all of these therapies are meant to be a complement to aggressive, heart healthy lifestyle adoption. And that includes that through diet, what we ingest, and our exercise regimen.
Right.
And so I would say it isn't the be all and end all that everybody has to achieve a certain weight. On the flip side, the, the correlate of that is that those who are really challenged, even with these medications, achieving an ideal body weight can attenuate their risk by maintaining the appropriate levels of physical activity and being fit overall. So I think they go hand in glove overall, but in somebody who is very fit, that has, let's say, the same weight as somebody who is less fit, I would still favor a reduction in body weight that's achievable safely if that can be achieved without a compromise of their diet, their lifestyle, their exercise regimen, and their fitness.
I want to ask you about diabetes. We mentioned that a few times. How is diabetes or elevated blood sugar harmful to the heart, the blood vessels in the heart and the brain? Why does it increase the risk of heart attacks and strokes?
Yeah, there are a wide array, similar to what we discussed before, of mechanisms by which diabetes itself, and calling out namely type 2 diabetes is what we talk about. It's important for both type 1 and type 2, but over 95% of diabetes in the United States today is type 2 diabetes. It tends to overwhelmingly and disproportionately occur in individuals with excess body weight. Having excess body weight does not mean that you will be guaranteed to develop type 2 diabetes, but you are at increased risk. And there are both direct and indirect, as we had sort of talked about beforehand, mechanisms for this. Indirectly, it increases the risk for other cardiometabolic abnormalities, including chronic kidney disease, which in and of itself has an interplay with the heart. There are derangements or abnormalities in one's lipid or cholesterol profile associated with that. There are changes in the substrate of what the heart uses from an energy perspective for its own function that are affected by diabetes. And so I would say that there are wide-ranging direct and indirect consequences. We know that diabetes is a risk factor not only for development of so-called atherosclerotic cardiovascular disease, namely heart attack, stroke, or development of blockages, most commonly in the arteries of the leg, but also other cardiovascular conditions, including conditions like heart failure. So it's often quoted that we had made some significant inroads in bending the curve downward in terms of the cardiovascular risks, so much so that we were looking to at one point potentially celebrate that cardiovascular disease is no longer the number one killer of men and women alike.
Right.
Unfortunately, the growing epidemic of obesity and diabetes, namely type 2 diabetes, driven to a large degree by rising excess body weight, has sort of turned that curve the other direction. And disappointingly and sadly, I sit here talking, saying, for both men and women alike, cardiovascular disease is the number one killer. And so my hope is increased attention and vigilance to the importance of weight reduction will have a favorable direct or indirect effect on the prevalence of diabetes, which continues to rise in the United States.
Right. You mentioned the risk factors. I read the recent CDC data. About 703,000 people die annually from heart attacks in the USA. It's a leading cause of death, as you mentioned. And could you just explain what a heart attack is? Because many of my patients don't understand what that means and what causes it.
Absolutely. And there are multiple mechanisms theoretically by which a heart attack could occur. And this gets slightly complicated. I'll take the simple approach, but it can be complicated that there are different types of so-called heart attacks or myocardial infarctions. When someone has heard about a family member, a friend, a colleague who has experienced a heart attack, in most circumstances, it results from over the course of their lifetime, the development of atherosclerosis, or the deposition of cholesterol and other deleterious components in the wall of the artery. And ultimately, a heart attack in most circumstances is thought to result from the rupturing, fissuring, eroding, cracking of that plaque or buildup of cholesterol in the wall of the artery that exposes blood traveling through that artery of the heart, also called a coronary artery, to substances below the level of the surface of the artery that is what we call prothrombotic, or predisposes to a clot forming. And in some types of heart attacks, what ends up happening is between the plaque or buildup of cholesterol and the clot that forms over it, it completely occludes the blood vessel, and there's no flow getting down the coronary artery. Or other types that are partially or incompletely occlusive, where the clot doesn't completely occlude the artery, but comes close to occluding it. And that's the mechanism for heart attacks. There are obviously treatments that we institute in the acute setting, primarily to prevent ongoing consequences from compromised blood flow down the artery of the heart. The mainstay of so many of the therapies that we initiate after a heart attack are principally to minimize the risk of buildup of cholesterol in the walls of the arteries, so-called plaque, from rupturing in the future. And that includes a wide array through diet and exercise, through cholesterol lowering therapy, through blood pressure lowering therapy, etc.
So basically, these are arteries. The coronary arteries supply blood to the heart muscle. And if those arteries get clogged up, the muscle doesn't get its blood supply, doesn't get its oxygen, and the heart muscle dies. And if enough of the heart muscle dies, then unfortunately you die as well. If it's just a small part that dies, then you might survive a heart attack. Is that a good summary?
I think it's a good summary. There are obviously individuals that suffer very large heart attacks and still survive, but
Right.
the larger the amount of heart muscle, as you stated correctly, that dies, the greater the consequence of potential complications in the
Right.
near term and the long term. The heart is a pump. If part of the heart's pumping function gets compromised, it's not as good of a pump. It may not work as well. Heart failure may ensue. The scar that results from a death of heart muscle can predispose to different types of arrhythmias and potentially life-threatening arrhythmias
Right.
or abnormal heart rhythms. So yes, there are a number of consequences above and beyond the most tragic, a loss of life,
Right.
is what permanent or longer term consequences is one left with above and beyond. And this is on top of a patient that has had one heart attack is at highest risk amongst all individuals of having a subsequent heart attack down the road.
Right. Now, you mentioned diet. I think that's important. People, I think, are confused as to what's a good diet and what's a bad diet. The Mediterranean diet gets a lot of attention. Can you tell us what the best diet is to maintain your heart health, prevent heart attacks?
Yeah, I would say the easiest thing to say is the best diet is one that you can be adherent to. And I say that a little bit in jest, but at the end of the day, we're trying to promote healthful behaviors that really represent a lifestyle change, not a short-term or near-term solution to facilitate weight loss in general. Often those go hand in hand, that we want to achieve healthful behaviors that promote long-term weight loss, but this is not a near-term problem. To that end, if I could wave a magic wand and say, is there an ideal diet from the standpoint of reducing the risk of cardiovascular events, helping to control blood pressure, promote favorable health going forward? It's often referred to as a Mediterranean diet. In the high blood pressure arena, you'll often see a DASH type diet. But essentially, this is a diet that is enriched with fresh fruits and vegetables, whole grain, polyunsaturated fats, in contrast to saturated fats, contrasting those by fats that are liquid at room temperature to contrast, like olive oil, to contrast that with fats that are solid at room temperature, like butter, and then really restricted in terms of other forms of saturated fat. Okay to have dairy, but having it be low-fat versions. Okay to have meat, but limiting the portion size and having lean meats overall. And I would say that whether we talk about it as the Mediterranean diet, what you frequently see for those that have ever traveled there is, people will eat a pretty varied range of different foodstuffs that they ingest, but it's all done in moderation. And I think as much as the content or components of the diet are important in what we ingest, so too is the amount that we ingest. And you can go awry if, in fact, you're eating what you believe to be healthful foods, but consuming too many of them as well.
Right. I'm a big fan of olive oil. I drink 2 tablespoons of olive oil every day for lunch because I've looked at all the Mediterranean diets, and the main ingredient, the common denominator, is olive oil. And there are actual studies that have been published that show that people who consume significant amounts of olive oil have reduced risk of heart attack and stroke. What do you think about the olive oil thing?
Yeah, I think polyunsaturated fats, of which olive oil is a key one, are a central component for those that are going to be cooking or consuming fats in their diet. There are other forms of polyunsaturated fats that are liquid at room temperature, and I think there are other forms of blended oils that can be used. One can go too far even with something like olive oil in the sense that excessive ingestion of polyunsaturated fats, even often perceived as healthy fats, can be deleterious as well. So I think this is a matter of in moderation, but giving strong preference to polyunsaturated fats as compared to saturated fats. I didn't mention it at all, but trans fats are modified fats primarily put forward through the food industry to improve shelf stability of certain foodstuffs as well. And we know that trans fats can be a particularly harmful form of fat to ingest. So you will see labels that highlight the absence of trans fats overall. One other thing I'll mention, and it is sometimes a little bit humorous how labels can be helpful, but sometimes perhaps a little misleading. Cholesterol in our diet principally comes from animal products. So if you're eating a pure plant-based diet, it's you're not going to be getting cholesterol through your diet that way overall. And so animal products are the major source of cholesterol. They're also a major source of saturated fats that we get in our diet overall. That is not to say that all individuals have to adopt a plant-based approach, but we have seen through some of the work that has been done by Dean Ornish and others that the adoption of a plant-based diet can have extremely favorable effects, not only in our risk factor profile and our weight, but overall our cardiovascular risk. And so this comes full circle to what I led with. You do what you can do. And there are people who will say, I want to become a vegetarian, I want to become vegan, we want to find ways to support them. And those that don't, how do you moderate the less healthful foodstuffs, really trying to promote fresh fruits and vegetables, whole grains in your diet as a complement to be an outsized component of what you ingest?
You mentioned exercise also. Why is exercise beneficial for the heart and reduces the risk of stroke and heart attack? Other than the weight loss that may accompany it, is there a direct benefit of exercise to the heart muscle and the coronary arteries? And which type of exercise best? Is slow walking okay, or do you have to do that high intensity interval training that's become popular in the last few years?
Yeah, so the recommendations put forward by our professional societies prioritize moderate to high intensity aerobic exercise as a key component of the exercise regimen. But resistance exercise is important to build lean muscle mass. It also makes you more efficient at burning calories for the same degree of aerobic activity that exists. And from the question that you led with, not dissimilar from what we've seen with the GLP-1 receptor agonists, not dissimilar from what we've seen from the benefits of losing weight in general. There are a variety of different favorable cardiovascular effects associated with exercise. This extends to it results in burning of calories, and ultimately, if not offset by a proportionate increase in calories or caloric intake, you will essentially lose weight. Uh, as a complement to that, this can help in terms of, or at building off of that, lowering blood pressure, improving your lipid profile or cholesterol profile, improving glycemic or blood sugar control in those with diabetes. And so there are a variety of different favorable effects. Again, I come back to the minimum requirements in terms of activity are rather modest by which to begin to achieve favorable effects. And so I certainly don't mandate that patients of mine get odometers or look at step counts, but studies that have looked at this in a very rigorous fashion have shown that even, we talk about 10,000 steps achieved per day, but even smaller percentages of that total daily step count can result in very meaningful favorable effects as it relates to the cardiovascular system and cardiovascular risk. So I would submit to individuals any amount is better than no amount. And selfishly, the more you're active, the more that is favorable cumulatively overall. There is a sort of plateauing whereby, obviously, from a caloric burning standpoint, you can burn more, but it isn't a one-to-one that if 10,000 steps is better, 20,000 steps must be twice as good as it relates to the heart, and 30,000. It isn't a direct linear response, but it really reinforces that even very small amounts of activity can have a tremendous effect, not only on the cardiovascular system, but other parts of the body as well.
Right. Yeah, exercise is key. I try to encourage all my patients. I want to get it into some of the testing that patients ask me about and I'm curious about. At what age should somebody get a baseline EKG or electrocardiogram to see if their heart's beating properly or if there's some abnormality? What do you recommend for your patients? Let's say a healthy person has never had a problem. Let's say there's no family history of any heart problems. When should they get that?
So there are no guidelines today that I'm aware of that recommend as a matter of routine in an unselected patient that they should get an electrocardiogram, also known as an ECG or an EKG. While there are insights that may come, and there are certainly anecdotal and more than anecdotal reports of, boy, I think my lucky stars that I got an electrocardiogram, it detected an abnormality, it led to testing downstream, and that made the difference. We do not recommend as a matter of routine getting electrocardiograms from a population screening perspective overall. Now, I'm going to mention a couple other things. Many people may have their first electrocardiogram as part of a life insurance evaluation. And we get patients who have been referred because they didn't intend to get an electrocardiogram, but it was required or requested of them. They got it, and it led to some additional testing. I would say the absence of abnormalities on electrocardiogram should not dissuade one of the potential risks that they may face if risk factors are not adequately controlled overall. On
Right.
the
So you could be obese, overweight, and have diabetes, but still have a normal EKG or ECG, right?
I'll go even one step further. An electrocardiogram looks at the heart rhythm and it looks at indirect signatures that may suggest abnormalities in either how the heart structurally works, whether there's compromised blood flow down the arteries of the heart, or they've experienced a heart attack. The flip of that is there are people who have abnormalities on their electrocardiogram, and when additional testing is done, perhaps to follow up on that, it doesn't demonstrate any clear abnormalities. So it's not an automatic in this regard. It's not perfectly sensitive nor specific to detect some of these abnormalities. Now, differences will exist if we're talking about individuals who have a family history of certain conditions, perhaps that are inherited, where you're then going to evaluate family members, and there may be a rationale to evaluate someone with electrocardiogram depending upon affected family members. But as a matter of routine, in an asymptomatic individual for screening purposes, not recommended.
All right, that's good to know. What about stress tests? Is there a certain age where somebody should have a stress test, which might show that there's a blockage of blood supply to the heart? And somebody has no symptoms, and let's say they're 60, 65 years old, should they have a stress test?
Yeah, and so some who are listening may also be familiar with executive physicals or screening programs that would involve stress testing as well. Again, there's more than anecdotal experiences of people saying, thank my lucky stars that I had this. It detected something
Right.
before it became problematic,
Yeah, I have
and
patients like that. Yeah.
it helped me. The data is very clear that there is not a recommendation to do stress testing in asymptomatic individuals. And let me just explain briefly why. Stress tests represent one of, a small handful of different testing modalities that may look for evidence of, at least in the case of a stress test, indirect evidence of compromised blood flow down the arteries of the heart. In general, and this is pretty well substantiated by a number of clinical trials, the benefits that are derived from opening up an artery of the heart, most commonly with things like coronary stents, coronary stenting, angioplasty, that the benefit conveyed to someone outside the throes of a heart attack or unstable cardiac event is primarily to make people feel better. And I want to be clear, there's data that suggests that medications may do just as good of a job overall. So if someone is truly asymptomatic, finding a blockage or blockages in the arteries of the heart does not and should not lead to downstream procedures to open up arteries, because the benefits would be making someone asymptomatic. And if they're asymptomatic to begin with, it begs the question of what benefit may be conveyed. And there are risks to that procedure. The only thing that I would say, and separate from stress testing, there are other tests where, based upon someone's risk profile and candidacy for cholesterol lowering therapy, there are tests like coronary calcium scans that may look at calcifications in the walls of the artery that may be a reflection of the burden of atherosclerosis they have. That test is principally helpful in determining, does the patient sitting in front of me warrant aggressive cholesterol lowering therapy? And in some cases, may help to reinforce healthful behaviors, where somebody says, you know what, I'm 55 years of age, I feel great. I don't need a healthy diet. I don't need to exercise. A visual pictorial display beyond, for me as a clinician, can be helpful to patients to reinforce those healthful lifestyle choices, not just in the short term and the long term. But as a
So is
matter of
there,
routine, we don't
yeah.
screen everybody with coronary calcium scans. There is guidance out there in the literature about how to use that type of test.
So do you recommend that test for, let's say somebody's 60 years old, they don't have any symptoms, no problems, no family history, their blood pressure is good, their cholesterol is good. Would you recommend that test just as a baseline, or do you need some other data or information to push you in that direction?
So it is probably the best test at helping to reclassify risk for an individual such as you described. Its principal value, perhaps beyond reinforcing healthful behaviors for the individual, is to determine whether cholesterol lowering therapy is warranted. So the scenarios that are outlined in the literature today, based on the cholesterol guidelines, is that everybody should undergo a cholesterol panel. The pediatric population begins even pre-teen years. And if, as you get older, because age is the strongest driver of cardiovascular risk, you begin to move into an intermediate risk in terms of your likelihood of having a heart attack or a stroke over the next 10 years, that's either fatal or non-fatal. If you move into an intermediate risk group, guidelines would recommend cholesterol lowering therapy. If for the patient in question, they're reluctant, debated, really don't see the value in going on cholesterol lowering therapy, the coronary calcium scan can help. If the coronary calcium scan demonstrates no calcification, it suggests that the estimated on the computer risk for that patient is probably an overestimate of the risk, and they can delay or postpone initiation of cholesterol lowering therapy, namely with a statin. If, however, the patient's amenable to going on cholesterol lowering therapy, and or the patient was reluctant, got the scan, and it showed calcification, that patient warrants cholesterol lowering therapy. And on the other end of the spectrum, if the patient's very low risk, the yield and value of the coronary calcium scan is very low. And on the flip side, if they're very high risk, then that value is non-existent. And this doesn't apply to people who have no coronary artery disease. It doesn't apply to the population that's had a heart attack, a stroke, stenting of their arteries, bypass surgery, other forms of vascular disease. Because that's a high-risk group, or maybe a very high-risk group, even from the outset.
Right. Let's talk about cholesterol. There are three different types that patients get tested for. It's the total cholesterol, the LDL or the bad cholesterol, and the HDL, which is supposedly a good cholesterol. Which one of those three is the most important to monitor?
Yeah, I would say LDL cholesterol represents our principal target and our primary form of cholesterol that we look at to make decisions. And you will hear lots of different people who say, my ratio looks really good. I have a very high good cholesterol. At the end of the day, LDL cholesterol represents the principal component that we look at to make determinations about whether cholesterol lowering therapy is warranted. There are essentially four groups of individuals: those that have established atherosclerotic cardiovascular disease, they've had a heart attack or a stroke. Those people absolutely require cholesterol lowering therapy, regardless of their LDL cholesterol. People who have very high elevations of their LDL cholesterol, greater than or equal to 190 milligrams per deciliter, they warrant amongst the most aggressive treatment of their LDL cholesterol. And then patients with diabetes warrant lowering of their LDL cholesterol. But as I was just discussing a moment ago, there are people who have none of those conditions, but based upon their age, their blood pressure, whether they smoke, their cholesterol levels themselves, they may warrant cholesterol lowering therapy. And I would just say we often have reference ranges or normal ranges for lab values that are included in almost all of our cholesterol, all of our lab tests, including our cholesterol panel. I find those directionally helpful, but patients can often be misled to say, my LDL cholesterol is in the normal range, but what's normal? And
Right.
normal is relative to the individual. A principle of cholesterol lowering is we are most aggressive in people at highest risk. We match the intensity of our LDL cholesterol lowering to the baseline risk of the individual.
Right. So I have patients, many, who are, let's say, 65 years old. They have no symptoms, no problems, no family history. Their LDL cholesterol is 125, and their doctor says, oh, don't worry about it. It's not too bad. What do you think of that? What is normal LDL? Because people who are 65 or 70, almost by definition, have some atherosclerosis. It's unlikely that they don't. So is 120 safe for an
So
LDL if you're 65 and have no other risk factors?
the overwhelming majority of men over the age of 60 or 65 qualify for cholesterol lowering therapy based on age alone as a driver of their risk. And the same is true, shifted a little bit, slightly older for women in that regard. So I would say if we were to plug in numbers that incorporate each of these components and ultimately were to arrive at an estimate of their risk for a fatal or non-fatal heart attack or stroke over the next 10 years, couched in decades of accumulated data, they would be a candidate for cholesterol lowering therapy. Let me do the flip side for you. I've also had people come to me and say, I know I had a heart attack, but my LDL cholesterol at baseline is 58. That is too high of a cholesterol for you by the nature of having had a heart attack. And so our guidance documents recommend both a percent reduction in LDL cholesterol and what's called a treatment threshold, a level below which you want to be below. If you're one of those but not the other, you haven't achieved your dual goal. So for all individuals that warrant cholesterol lowering therapy to principally lower LDL cholesterol, you're going to want to achieve a certain percent reduction and get below a certain level. And that level and that percent reduction is different for the different groups that I outlined previously.
Right. Now, wouldn't we automatically save possibly tens of thousands or hundreds of thousands of lives a year if everybody over age 60 had an LDL below 70? Just kind of randomly. That's your number. We got to get you below 70, even if you have no other risk factor. Wouldn't that reduce the amount of heart attacks and strokes and other problems?
To reinforce what your great question asks, when you look at LDL cholesterol absent having a genetic abnormality that predisposes to high levels since birth, and you take blood off of your umbilical cord, LDL cholesterols are 30 to 35 milligrams per deciliter. Hunter-gatherer populations around the world that are really devoid of exposure to westernized lifestyle, and they hunt and forage for food, rarely have LDL cholesterol levels above 40, and they rarely develop atherosclerosis. So to your point, getting lower levels. Now, this invites a lot of population level questions of how many people do we treat ultimately, but with the wide availability of largely safe, effective therapies to lower LDL cholesterol, you are correct from a population health perspective that getting LDL cholesterol levels down would be very advantageous from a cardiovascular prevention, preventive health perspective in saving lots of lives and reducing the rate of adverse events overall. So unequivocally, I agree with you in this regard.
Well, that's good to know. Now, the main treatment is statins initially, right? That's a treatment for lowering LDL cholesterol. Are there better statins, or are they all the same? There are several different ones that are available.
Yeah, so there are a wide array of statins that exist. I'll go one step upstream. The base approach is lifestyle intervention through diet and exercise.
Right.
And although it wasn't at all inferred by your question, I will say, anecdotally, I'll have patients who say, you know what, I'm taking a statin. I really don't have to watch my diet very carefully. Isn't that right? And the answer is that may be intuitive to you, seemingly logical to you, but that's not how these drugs were studied, and that's not how they should be used overall. Statins represent first-line therapy in our European and American cholesterol guidelines. They represent the base first approach. Statins vary in terms of their intensity. There are some that per milligram of the drug achieve greater degrees of LDL cholesterol lowering. And then there are doses of statins. And all of the statins that are FDA approved vary in their strengths. I will say that a common theme among statins is you generally get your biggest bang for your buck at the initial dose of that drug. Now, your clinician, your care team member may well prescribe you the highest dose of a potent statin, and I do for many of the patients that I see. But mathematically, numerically, you get your greatest bang for your buck with that initial dose, and you get incremental LDL cholesterol lowering, just not as much as you got the initial dose. Wherever possible, since we're trying to match the intensity of the LDL cholesterol lowering to the baseline risk, those at highest risk, either by the nature of having very severely elevated levels or having demonstrable disease, those individuals warrant even more aggressive use of statins, namely higher doses of the higher potency, more potent statins.
What about a drug like ezetimibe? Some of my patients are on that in addition to the statins. When do you use that drug? Or can it be used alone without a statin?
It could be used alone without a statin. Generally, we reserve it as being used alone for people who otherwise don't tolerate not just one statin, but at least two. And in my case, I will frequently go to 3 or 4 statins to try and make sure patients have limiting tolerability before exploring a so-called non-statin. Ezetimibe is the first of the non-statins. It is not a statin. It does not work by the same mechanism. It only occurs in a single strength. It has been studied on a backdrop of statin therapy and shown to provide incremental cardiovascular risk reduction, in contrast to the most potent statins at the highest doses that achieve upwards of a 50 plus reduction in LDL cholesterol. Ezetimibe will achieve about a 20 to 25% reduction in LDL cholesterol, and it's a complement too. So going back to what I had shared previously, since there are dual goals, a percent reduction and getting below a certain level for every patient treated with cholesterol lowering therapy, failure to achieve those two dual goals on maximally tolerated statin therapy should invite the addition of non-statin therapy. Ezetimibe tends to be the first because it's oral, largely well tolerated, generic, and therefore less costly for most patients.
Right. I have more and more patients now who are taking Repatha or Praluent. They're getting injections because they had either liver problems from the statins or some people have muscle aches. Are those being used more, or is it easier for some patients to just do the injections every few weeks or month rather than taking pills every day?
So you're asking great questions. These are the so-called PCSK9 inhibitors, and there is another PCSK9 inhibitor. Um, Repatha has another name, evolocumab. Praluent has another name, alirocumab, and then there is a drug, glycerin, that is a brand name, Leqvio. Those constitute injectable so-called PCSK9 inhibitors. Mechanistically, they work to result in higher amounts of LDL cholesterol receptors on the surface of the liver. More receptors mean greater clearance of LDL cholesterol from the bloodstream. I would say we rarely, if ever, use these drugs alone or even in combination with ezetimibe without a statin, unless patients do not tolerate at least two, and in my case, exploring even more than 2 statins in patients overall. Recognize I may have some patients labeled as statin intolerant, but I can dose them with a low potency statin that's used at a low dose that may be dosed every other day, twice a week, and people can get some degree of additional LDL cholesterol lowering with that overall. So where possible, the PCSK9 inhibitors are used as a next line of therapy, usually following up the sequence of maximally tolerated statin therapy for those that need additional LDL cholesterol lowering, ezetimibe, and then adding next the PCSK9 inhibitors. Another drug, bempedoic acid, that goes by a brand name Nexletol, is another adjunctive oral therapy working by a different mechanism to help lower LDL cholesterol. The PCSK9 inhibitors can achieve 50 to 60% additional LDL cholesterol lowering on top of statins and ezetimibe. Bempedoic acid achieves less LDL cholesterol lowering than that. So, and we're going to see probably in the next several years, even probably at least 2 other therapies coming down the road that can be a complementary means by which to help lower LDL cholesterol, again, trying to get lower and lower levels. And our most recent document put out by the American College of Cardiology in 2022 notes that for those at very high risk who have atherosclerotic cardiovascular disease that had a heart attack, stroke, bypass surgery, that we try and shoot for an LDL cholesterol less than 55. The Europeans, even at the various highest risk individuals, will push that level even lower. And I do want to reinforce, we don't need cholesterol circulating in our bloodstream. We do need it to make our cells and functioning cells but we don't need it in our bloodstream. So you'll hear about people who have even LDL cholesterol levels in the teens, single digits. And in the absence of tolerability, don't back off on their medication because it is conveying a lot of the benefit that we would want these therapies to provide.
All right. So LDL cholesterol is the enemy, and we need to get it down. What about aspirin? The aspirin story changes every couple of years. Years ago, everybody should be on aspirin over age 60. Then, oh, well, not everybody because it may cause bleeding. Oh, well, if you have a history of heart disease, family history, maybe you should take it or not take it. What's the latest on aspirin? Who should be on aspirin?
In the absence of another blood thinner that may take precedence in this regard, aspirin is recommended generally at a low strength. In the United States, 81 milligrams of so-called baby dose aspirin in those that have so-called atherosclerotic cardiovascular disease. So if you've had a heart attack, if you've had a stroke, if you have vascular disease involving the arteries of your legs, low dose aspirin is recommended. Now, to be clear, for many of these groups, they may be on more than one blood thinner. So in addition to aspirin, they may be on other so-called antiplatelet agents, or conceivably could be on a so-called anticoagulant, another type of blood thinner. The biggest attention that was brought about and updated in most recent so-called primary prevention guidelines was, should somebody who doesn't have vascular disease but has diabetes, or doesn't have diabetes but is at increased cardiovascular risk, should they be on aspirin to mitigate the risk of developing a first heart attack or stroke? And the totality of the data would suggest for an unselected broad population at risk, with or without diabetes, that there either is equal benefit to harm, that there is some benefit, but it's offset by increased bleeding risk, or there may be a net harm, and that the bleeding risk brought about because of being on an antiplatelet blood thinner overwhelms the benefit that would be derived. I will just mention, going back to coronary calcium scans, that there is data from a large analysis of individuals who didn't have clinically evident atherosclerosis, buildup of cholesterol in the walls of the artery, but had so-called subclinical atherosclerosis, an elevated coronary calcium score, that individuals who had calcium scores greater than or equal to 100, and certainly greater or equal to 400, those individuals had a favorable net benefit from aspirin compared to not being on aspirin. So by and large, a majority of individuals that were deemed to be at risk, but so-called primary prevention because they had not been diagnosed with a heart attack or stroke, had bypass surgery, angioplasty, those individuals no longer in a broad group weren't aspirin. But if you've been diagnosed with vascular disease, absent being on an alternative blood thinner or a combination of blood thinners, you should be on low-dose aspirin.
Good to know. Now, there's some other tests that are become available other than the LDL cholesterol. One of them, the lipoprotein A blood test. Apparently, people who have elevated levels of that have increased risk for heart attacks. Can you tell us about that test, and when do you do that test, and who do you do it on?
Yeah, some people have referred to lipoprotein A, lipoprotein little a, LP little a, these are all synonyms, as sort of the perfect recipe for a heart attack. It increases the risk for atherosclerosis, buildup of cholesterol in the walls of the artery, and it also potentiates increased risk for clotting. And it is heritable. It's genetically predetermined. And it's estimated that as many as 1/5 of individuals, 20%, can have an elevated level. Now,
Wow.
there are elevated levels, and then there are very elevated levels. And so the risk faced by that individual is felt to be at least proportionally related to how elevated the level is. Now, this gets complex because you might say, if we've known about this for a while, why are more people not being tested?
Right.
And
Most of my patients aren't tested.
yeah, and for acknowledgement, the National Lipid Association, the United States, the Canadian Professional Society, European professional societies have advocated that everybody should get tested at least once. Get one value to understand where their level is, given the fact that it's genetically predetermined. The counter argument to that is we've had few to no therapies that have been shown to reduce cardiovascular risk by lowering Lp(a). And we do have drugs today, like the PCSK9 inhibitors, that lower Lp(a) levels by about 25%, but they're principally initiated based on criteria based on one's LDL cholesterol. And so I think the challenge is, does knowing for knowing's sake help? And where the guidelines or guidance that has been issued by other professional societies that does not endorse everybody getting tested, it does recommend its use in people who have premature atherosclerotic events, heart attack, stroke at a young age, with a paucity of traditional risk factors, people who have a family history of premature events that you don't understand why your mom, your dad, a brother, or sister experienced an event, people with recurrent events. So I think that there is growing agreement amongst professional societies that higher risk individuals absolutely warrant testing. There is a camp that would endorse widespread testing for everyone. I think if we see, as there are trials ongoing today, looking at novel therapies to lower Lp(a), and we know that these drugs do that, what we're missing, the final piece is, does that translate into cardiovascular risk reduction on top of standard of care therapy for LDL cholesterol lowering? If the data is strong and convincing, then you will begin to see probably a fervent effort to test people for Lp(a) levels. The complexity of this is the overwhelming majority of the trials evaluating these agents are studying it in people who have higher levels and for people that already have atherosclerotic disease. So the piece that we will have avoided, even if we have drugs that show that they can lower Lp(a) and lower cardiovascular risk, is these will largely be restricted to people who have Lp(a) levels above a certain level and who have established atherosclerotic cardiovascular disease. So what do you do if you find your Lp(a) level is very elevated, but you've never had an event overall? The last thing I'll mention is there are other conditions like aortic stenosis, a form of valvular heart disease, that are tied to elevated levels of Lp(a). So it's not purely just heart attacks and strokes. There are other forms of vascular or other forms of cardiac disease that may be at play.
Right. I know I'm not a cardiologist, but it seems to me like there's almost no downside in getting everybody checked for the lipoprotein A, maybe by age 40. And if somebody's 40 and has an LDL of 110, but has no other problems, you might want to treat that more aggressively. So I think also we're trained in medical school and in all our internships, residencies, fellowships, that we have to have prospective clinical trials that go on forever on hundreds of thousands of patients to prove certain points. And I think sometimes those may get in the way because they take too long to accomplish, they're too expensive. And by the time we figure it out, we may be losing some lives. But that's my ophthalmologist's opinion on
I would agree with you just off the cuff to say that having more information to make better informed decisions about lifestyle, diet, and exercise, and certainly the use of LDL cholesterol lowering therapy makes perfect sense.
right.
I'm just calling out the challenges.
Yeah.
We are going to be on the precipice in the next few years of having newer therapies for which we don't know whether or not they're effective in preventing a first event. We don't know whether they're cost effective in a patient population that hasn't been studied. This is the rub to your point of we like to have every decision couched in really robust data. I think we're going to need additional data for some of the people that we talk about who have not had events or have moderately elevated but not severely elevated levels.
Now, what about apolipoprotein B100? That's a even newer test, and apparently that is even a bigger risk factor than the little lipoprotein A. What's going on with that test?
Yeah, so ApoB or apolipoprotein B, we've known about for a very long time. And ApoB is a protein present on all of the so-called atherogenic lipoproteins. The lipid molecules, if you want to think about it, that are pro-atherosclerosis developing. So it would make sense to say, if LDL is good, boy, wouldn't it make sense for everybody just to get an ApoB level, because we know what levels are normal versus not. And we would expect that in people who have high levels of ApoB, they're enriched with a higher likelihood of developing atherosclerosis. It all makes sense, and I will acknowledge that, just for those less familiar with this, LDL cholesterol in most cases is a calculated value. It's actually not directly measured in most individuals. It's plugged into a formula, and there are limitations to that formula. It's not perfect, and there are different formulas that are out there that are better, but it requires questioning whether the lab that you go to uses one of these newer formulas overall. So some have asked the question, is ApoB a better mousetrap than LDL cholesterol? And in testing to determine whether or not it is, it suggests that likely ApoB outperforms LDL cholesterol in terms of its ability to predict cardiovascular events or risk. However, when you get a standard cholesterol profile for free without doing any other testing, you should be able to get, and if you don't get it automatically, you can easily do the math, so-called non-HDL cholesterol. And non-HDL cholesterol is everything that is not HDL or good cholesterol. So it is essentially looking at those components that are not so-called good cholesterol. And when you do comparative analyses for a free test like non-HDL cholesterol and look at its performance compared to ApoB, they're fairly similar. There are some exceptions for which ApoB testing makes sense, but since you get non-HDL cholesterol standardly with the usual cholesterol profile, you can ask your clinician, what's my non-HDL cholesterol? That gives you an assessment. And if your clinician told you your LDL cholesterol goal is less than 70, for most people, their non-HDL cholesterol is 30 milligrams per deciliter greater. So if you wanted to be less than 70 for your LDL, you want your non-HDL to be less than 100. That's a rough back of the envelope rule in this regard.
What about another test, the C-reactive protein, and specifically the high sensitivity cardiac C-reactive protein? My understanding is there's a correlation between that test being elevated and also cardiac problems.
So C-reactive protein is a barometer or a marker. It's a biomarker of inflammation. Lots of different inflammatory processes can cause its elevation. High sensitivity C-reactive protein is just a more sensitive assay or blood test that allows a more robust detection of lower level elevation or modest elevation of that molecule. There is a tight intersection between inflammation and atherosclerotic risk, such that we believe that inflammation can be an underpinning of the development of atherosclerosis and the likelihood of developing adverse events related to atherosclerosis, namely heart attack, stroke. And there have been some very elegant analyses done in the past to show that people who have higher levels of high sensitivity C-reactive protein portend or are associated with increased cardiovascular risk. So on the one hand, it may be a useful, what's often referred to as risk enhancer, that if you had somebody without atherosclerosis who had an elevated hsCRP level, it would convey another risk to that individual or a marker of risk, suggesting that the person sitting in front of you appears to be at higher risk than somebody who doesn't have an elevated level in this regard. It is important to recognize that there are different things that can affect one's hsCRP level, so there is often a rationale to repeat it. Less clear data for its use in people who already have established atherosclerotic cardiovascular disease. And then just one thing to call out, if inflammation is the source of some of the problem, should we be using anti-inflammatory agents? Statins have an anti-inflammatory component. They lower hsCRP. There is a drug that's FDA approved now to reduce cardiovascular risk, colchicine, which has anti-inflammatory properties. And there are other drugs under evaluation now that principally target inflammation, being looked at to see if they provide benefit in wide-ranging conditions from atherosclerosis to chronic kidney disease to heart failure. And so we may see a targeted approach targeting inflammation overall in populations like this in the future.
Right. And colchicine's a pretty safe drug. It's been around about 100 years. It's been used for treating millions of people with gout. At the level recommended, 0.5 milligrams a day, it seems like a very safe drug for somebody who has elevated CRP levels, but no other inflammatory diseases going on. So
Let me just
like
say
that.
we don't have data in the so-called primary prevention population for colchicine to reduce cardiovascular risk in that group. The preponderance of data for colchicine has been studied in trials of looking at people with various forms of cardiovascular disease, heart disease, coronary artery disease overall, after a heart attack with stable disease, etc. So the guidelines don't prioritize it as a first highest level recommendation, but a little bit further down. The only other thing that I would say to add complexity to this is the trials that evaluated colchicine did not regularly evaluate hsCRP as part of the trial design. So what we don't know is the benefit of colchicine consolidated in so-called secondary prevention in patients with heart disease in those that have higher levels of inflammation. It makes perfect biologic sense that would be the case. We just don't know for certain. And it does make sense to say, boy, if you're walking around with higher levels of inflammation, maybe the anti-inflammatory would help to reduce the risk. The reality of the situation is that a cost-effective intervention for unselected patients who just have an elevated hsCRP level? We don't know. And so we would need further data to help inform that overall.
Here's another controversial subject. For years, they used to say that red wine actually helps your heart if you drink it in small amounts or moderate amounts. Recently, I've seen where the opinion is opposite. All wine is bad, all alcohol is bad. What's the story with alcohol, wine, and heart disease, strokes?
Yeah, I would say historically there was a question that perhaps giving even preference to red wine over other forms of wine and their white wine. And the belief is that there were components in the wine that may have an anti-inflammatory effect or a anti-atherosclerotic effect in terms of heart disease overall. That has really not borne itself out in terms of studies. And I'm going to acknowledge that we have not heard about large studies being done having people get randomized to red wine versus no red wine. You can imagine the complexity of conducting such a trial. And then on the flip side, alcohol broadly can have some deleterious effects. It raises blood pressure. Some people who especially don't like it would freely say these are empty calories that I'm consuming, and I don't really like it. So there's no guidance out there that would say you should drink even small amounts to reduce your cardiovascular risk. Whether people who enjoy drinking very modest amounts of alcohol, unrelated to promoting cardiovascular health, whether there may be some component of cardiovascular benefit, there may be. That all being said, if you're having challenges with blood pressure, this can raise your blood pressure. If you are having challenges with weight, these are calories. So I think it is certainly not the first, second, third, or you can imagine where I'm going in terms of numbers of recommendations that I would offer up to encourage people, rather really calling out the more concerning thing is I have patients of the belief that if some is good, more is better. So therefore I should be drinking not just one glass, but 2 glasses and 3 glasses. And the net effect in that situation, heart and beyond, is it probably causes harm that offsets any benefit if it exists.
Yeah, there's increased evidence that it increases cancer and other problems. I think right now, the best bet is to avoid alcohol as much as possible. Best bet. We've been talking now about prevention. I want to go into something that has recently been in the news a lot, and that is myocarditis or inflammation of the heart muscle. There have been reports of that from the COVID infection, and then some people believe that it's actually the vaccine that causes the myocarditis. I've also had some patients who develop cardiac arrhythmias like atrial fibrillation after receiving the vaccines. Of course, that arrhythmia is common in that age group anyway in elderly patients. So what's the story with myocarditis, COVID, vaccines, arrhythmias? Do we know?
Yeah, I guess I'll give a cumulative sort of totality of what we understand today. So the term itis means inflammation. If you have appendicitis, you have inflammation of your appendix. And if you have myocarditis, you have inflammation of the myocardium, the heart muscle. Pericarditis being inflammation of the sac or lining around the heart. So that's what itis means. We know well predating the pandemic by decades and decades that a wide array of, in particular, viruses can cause myocarditis. It's not common, but when it occurs, it can be a mild illness with fever and often constitutional symptoms, and it can progress all the way to a point at which patients have overt heart failure, shock, and even a risk for death. During the SARS-CoV-2 pandemic, COVID-19, now obviously in 2024, we continue to recognize the fact that that virus has the potential of causing myocarditis, inflammation of the heart muscle, and inflammation of the lining of the heart called the pericardium or pericarditis, or both. Again, it is a fairly uncommon consequence of having the illness itself, and it can not occur with the first time you've gotten the viral infection, but occur in a subsequent time. We learned relatively early into the rapid desire to develop a vaccine that the vaccines most commonly administered in the United States for not only the initial vaccine series, but also the boosters, that there is a low risk of developing myocarditis or pericarditis, and there is a greater propensity to occur, even though very infrequent, it occurs at a higher frequency in young men compared to young women or older age men and women in general. The course of illness associated with a viral form, virus-related myocarditis, tends to be a more greater potential for having serious consequences. In contrast, those who develop myocarditis related to the vaccine tend to have a less serious consequence on average. And there are exceptions to everything I just said overall.
Right.
And then in the midst of having inflammation of your heart and or inflammation of the lining around the heart, you can have arrhythmias and other forms of cardiac disease. And then, unrelated to what I was just discussing, we do recognize that there is an entity referred to as long COVID, where people who have had the viral infection can have symptoms or different disease processes that develop more than 4 weeks, more than 3 months out from their viral infection. This is not restricted to people that landed themselves in the hospital or the intensive care unit, but even people who had very mild illnesses managed in the outpatient setting. We believe that there is a propensity because of their immune system, as at least one component of long COVID, to increase the likelihood of having symptoms. And there have been some elegant studies done showing that people who have long COVID face increased cardiovascular risks, including common disease processes like heart attack, stroke, arrhythmias like atrial fibrillation, and other forms of cardiac disease as well. So I believe strongly that at least from the data that we had from the earliest periods of the pandemic, that there is a net favorable benefit to vaccination in terms of the risks of even myocarditis alone, protecting against viral associated infection related myocarditis relative to that from the vaccine The highest risk group are males in their teens and 20s. And that being said, the likelihood of developing it amongst males in their teens and 20s is still very, very uncommon overall.
Interesting. I guess we'll need some more data over the next few years to figure it out. Last thing I want to bring
Yeah.
up is up to now, we've been talking about prevention and certain diseases. I want to make it clear to people watching this that certain types of symptoms, heart symptoms, should bring them to the emergency room immediately rather than listening to shows like this or calling their doctor. Could you just tell us what the symptoms of a heart attack are and when should people go to the emergency room or call an ambulance?
I don't want to talk out of both sides of my mouth, but as you can imagine, chest pain, pressure, heaviness is one of the most common presenting symptoms to the emergency department. Most people coming to the emergency department with chest pain are not having a heart attack or other serious forms of heart disease. However, it's very hard sometimes to sort that out. And the more that you are having new worrisome symptoms of chest pain, pressure, heaviness, shortness of breath, or what are often referred to as other additional symptoms, arm pain, jaw pain, neck pain, and you don't know what it is, it's worth seeking medical attention to figure out what this is. That's even more so if you have a higher age. You have high blood pressure, high cholesterol, diabetes. You should not be falsely reassured if you don't have those risk factors. So in the event that you have, in particular, the acute onset, sudden onset of chest pain, pressure, heaviness, jaw pain, neck pain, arm pain, shortness of breath, and you don't know what's going on, getting further evaluation, timely evaluation is of key importance.
Right. Because if you are having a heart attack, if it's treated properly, it can sometimes save your life or damage to the heart.
World of
That's,
difference.
that's really good to know. Well, this has been extremely informative, educational for me, and I'm sure the audience out there as well. And I feel like I've done an hour and a half cardiac fellowship with you here in the last hour and a half. So I really want to thank you very much for taking the time from your schedule to tell us about all these very interesting things. And I think this will get lots of people to lose the weight, control their blood sugar, and go see their doctor if they're having any symptoms or problems. Thank you very much.
My pleasure. Thanks for having me.